So Dr. Kiona Allen is a pediatric cardiac critical care physician and the interim medical director of the cardiac care unit at Lurie Children's Hospital. She's the medical director of the Lurie Children's Single Ventricle Program and a work group co-lead in the Fontan Outcomes Network. Kiona will be presenting a talk entitled How Learning Networks Have Changed the Practice of Medicine. Dr. Allen, take it away.
Thank you, Katie. And thank you, Diane. I agree. I love listening to you, and it really, a lot of those themes will be echoed in my talk about how learning networks have changed the practice of medicine, both as far as the outcomes and as far as how it's impacted the providers. You've already heard from Carol about the evolution of NPC-QIC and now FON, and from Diane about co-production. And I think what we're trying to highlight is that the growth of the learning network concept has been transformative over the last decade or so, not just NPC and FON, but collaboratives in a variety of fields and arenas. These typically involve a registry with an additional quality improvement component. And this work has really brought together individual patients and providers into a broader framework that can affect outcomes. So that's sort of how I'm going to walk through it. So maybe this is self-explanatory, but what is a registry? It's a database created to track the progress of a disease over time for individual patients. And for relatively rare diseases, this is a way to collect pooled information, since it may be really hard for a single site to have enough patients or experience to obtain that data on their own. If you have, even in a large center, 40 Norwoods a year, and in a small center, 4, it's just very difficult to be able to do the level of research and data collection that's going to be meaningful for us to move the field forward. The goal of the registry population is to be a balanced and representative sample of the broader population with the disease, so that the lessons learned can be relevant to everyone else. Registries can be used for information gathering, benchmarking, or research, but this does not necessarily include interventions or collaborative efforts. And so a learning network or quality improvement collaborative takes this one step further. Rather than just measuring stuff, learning networks and quality improvement collaboratives try to actually do something about it. So a learning network is a multi-site collaboration that focuses on quality improvement, research, as Diane has pointed out, patient and family engagement and community building, and understanding variations in clinical care, and in turn, reducing unnecessary variation and trying to determine best practices that can improve patient outcomes. Again, this can be particularly useful for rare medical problems, because in these cases, work can be done right away, rather than trying to recruit patients into a randomized controlled trial that in a limited patient population might take decades to carry out, and even longer to see clinically relevant results. Use of a registry allows us to take the small experience of each individual center and add that up to equal big experience. In 2006, the Joint Council on Congenital Heart Disease set a goal to create a QI initiative that would improve care and outcomes for kids with cardiovascular disease, and NPC-QIC was born out of this effort. But the principles laid out by the key stakeholders in that conference, representing all the major pediatric cardiac professional organizations, surgeons, cardiologists, et cetera, have shaped the way NPC and networks like it are organized. And most importantly, it laid out explicitly that a major focus had to be assembling a broad network to foster collaboration and shared learning. So again, including patients, parents, families, providers from all the important related specialties, all working together to improve outcomes in real time. So I think we are familiar with some of our own learning networks, but there are lots of examples, not just in cardiology, but in a variety of specialties and disease entities, ranging from prematurity to inflammatory bowel disease, cystic fibrosis. It was a major part of some of the innovative work that the Affordable Care Act was trying to do to partner community centers together to improve general pediatric outcomes. Obviously, NPC-QIC Action, which is for heart failure in VAD patients, and the Fontan Outcomes Network are part of a growing cardiac network collaboration, which also includes PC4 and PAC3, which track inpatient cardiac admissions, and CNOC, which tracks neurodevelopmental outcomes, all things, as Diane pointed out, that people are really passionate about and will include FON in the long term. And these registries and their associated learning networks are bringing together centers from all over the country to help us understand our outcomes as a field, benchmark against each other, and identify improvement opportunities both at individual sites and network-wide. And rather than reinventing the wheel for each one, through Cardiac Networks United, they're able to link together in a way that allows you to pull data from each one into the others so that the lift of trying to get the data into the registry is not quite so much. So how does this work? Once a specific patient population is identified, expert stakeholders, that includes clinicians, parents, patients, and partners, select key drivers or specific areas of focus that will drive the collaborative efforts. Based on these key drivers, a registry is created that allows the group to understand the population and their current outcomes, and to be able to monitor any changes to that population and to their outcomes over time. So this means that your database has to have enough detail to be able to draw conclusions, but not be so painful that nobody is willing to take the hours and hours that it would take to enter the data. So it has to be skinny enough, but also granular enough for you to be able to actually interpret the data. The first step allows us to assess, where we are, like right now, by studying current care processes and outcomes at the member institutions to identify high and low performing centers. And this is often where a registry stops. So the IMPACT registry, for example, was created by the American College of Cardiology to look at use, risk, adverse events, and outcomes associated with cardiac cath. The registry elements were chosen to help risk stratify the case mix at any individual program to improve our ability to make inter-center comparisons. There are over 100 hospitals that participate in IMPACT with over 100,000 cath encounters logged. Centers have access to their own data, which allows them to benchmark against other institutions and to design QI interventions locally. But there aren't really registry-wide QI initiatives, and as a result, there haven't really been demonstrable changes in the outcomes that matter for the participating registry centers, like as a whole, as a network. And so this is where a learning network comes in, because it moves one step further. As the data is collected, each center forms a team that will become a local learning collaborative. And these teams are usually made up of champions from the critical domains relevant to the work. So patients and parents, physicians, nurses, case managers, therapists, dietitians, surgeons, et cetera, depending on what the specific project and what the specific problem is. It's critical for each center to identify the critical stakeholders that they can draw upon to build a robust team. These teams become part of longitudinal learning that uses direct collaboration and improvement science to disseminate knowledge gained from the registry. So for NPC-QIC and many networks like it, this is all organized based on the Institute for Healthcare Improvement's Breakthrough Series model, mostly organized through facilitated learning sessions that serve as a forum to share current knowledge and think about future directions. So for NPC, for example, that happens in a giant forum every fall and every spring, with sometimes learning labs or smaller sessions that take place in between. At these learning sessions, change ideas are introduced for teams to take back to their own centers. And additionally, each individual team and the network as a whole spend time brainstorming about the next set of concrete interventions they want to tackle, with support and coaching from the QI experts that the network is able to provide as part of their resources. In between the formal learning sessions, centers keep trying to share knowledge within their team and with other teams through site visits, conference calls, listservs, discussion boards, smaller group projects. And so in this framework, each center has something to teach and each center has something to learn, or all teach, all learn, as Carol already pointed out. The intervention brought home to the local center is itself a learning opportunity that is then transparently shared back with the entire group. And this work informs future PDSA cycles moving forward. So does this framework actually affect outcomes that matter? People are investing a lot of money and resources into these networks. So is it actually making a difference? I mean, I think even outside of our networks, our cardiac networks, there are a lot of examples of how this is making a tremendous difference for patients and families. The Vermont Oxford Network is an international NICU collaborative with 1,400 member centers that's focused on improving neonatal outcomes with data-driven QI and research. They've documented improvement in a variety of important outcomes in their member institutions, including a reduction in infections, necrotizing enterocolitis, intraventricular hemorrhage, and retinopathy of prematurity. Similarly, Improve Care Now is a network that includes 30,000 children with inflammatory bowel disease from over 100 centers across the world. They similarly collect data, monitor individual and overall performance, compare outcomes, and try to establish best practices in order to rapidly roll that out across the network. And since their creation about a decade ago, they have increased the number of kids in remission from IBD across the network centers for both Crohn's and ulcerative colitis. NPC-QIC, we've already talked about, includes now over 60 centers and has demonstrated substantial reductions in our outcomes that matter, including mortality and growth failure in the interstage period. At this point, there are, as I said, nearly 70 care centers in 3 countries with teams made up of patients, parents, clinicians, and researchers. There's over 1,400 patients in the registry. And in addition to the quality improvement projects that have been successfully rolled out network-wide, there have also been numerous publications resulting from the registry data that would have been very difficult to accomplish any other way. I'm not going to go through them all, but here is just like a smattering of them vomited on this page. Diane already talked about the digoxin study, which I think has been quite impactful on our field, but there have been others that we would never have been able to collect this data any other way. And so, it's not completely without difficulty. Participation in any individual collaborative can be expensive, and many centers end up participating in multiple collaboratives, and that can definitely add up. Most of the organizations have a participation fee in addition to labor costs required to maintain participation. So data specialists, research associates, clinician manpower, and time to get the data into the registries, the actual QI work itself, attending the learning sessions, all of that can be a lot. But I think that for my center, all of these registries, which we participate in all of them, have already more than paid for themselves. We've been able to help spread knowledge and skill. I think Diane has already talked significantly about the social pressure that has been applied to engage clinicians. That's certainly been true within cardiology. I think another good example of that is the Cystic Fibrosis Foundation, where if you're not a benchmark center for them, if you're not a center that's keeping up with the benchmarks that they're setting, people don't go to you anymore. So it's actually transformed the way that care has been regionalized across America for patients with CF, and I think that is starting to happen for cardiology as well. It's allowed centers to pool resources to overcome barriers and empowered patients and families. And this is just an example of the outcome improvement in a variety of those other networks that I've talked about, including Improve Care Now and the Children's Hospital Solution for Patient Safety, which focuses on hospital-acquired infections, NPC, and then there's an Ohio Birth Hospital Registry that has been able to shift outcomes for premature patients. The Ohio Solutions for Patient Safety, it's called. So for our center personally, while we've benefited significantly from the network-wide change packages and learning networks, we've also used the learning sessions to look at our own performance and identify areas for improvement. So at the fall of 2018 learning session, we were shown this data. This isn't the real data because we're not really supposed to share that. So I made this chart so it looks like a funnel plot, comparing our percentage of patients on all oral feeds at their first birthday to the rest of the network. So for those of you who don't really have experience with funnel plots, the simplified version is that the red line is the center line, or sort of the network-wide average performance. The blue lines are the control limits, meaning that if you're outside of those lines, you're kind of an outlier, either good or bad. We weren't an outlier, but we, and more importantly, our parents who attended this conference with us and saw this red star, were not satisfied with this performance. We were well below the center line, and so we decided to do something about it within our own institution. So encouraged by some of our patients' experiences with very, very expensive private tube weaning programs, we created a pilot program in which we enrolled essentially every medically eligible and interested interstage graduate into a structured NG tube weaning project that was run by our interstage team. So anybody who still needed NG feeds 6 weeks after their Glenn was eligible, and we committed to completing that wean prior to transitioning them out of interstage home monitoring. So by August of 2019, so about a year in, we had identified and enrolled nearly half of our interstage patients, so like half the patients were still requiring 2 feeds, which is exactly what we thought we needed to improve. And as we built our confidence, we were able to take on more and more complicated patients, ex-preemies, kids with aspiration or feeding intolerance, kids with congestive heart failure symptoms. Really, the only barrier that we found is an occasional medical comorbidity, but mostly it's been parent interest. And it's worked. Not only did we successfully wean all 10 of those pilot patients, we've continued the program with tremendous success and have now weaned over 30 patients. All but 2 of them have remained entirely PO fed since the wean, and both of those 2 are now back to all PO feeds. And we haven't had any major complications, no readmissions, no electrolyte issues, no malnutrition concerns. And more importantly, through NPC-QIC, we've been able to partner with other centers who have been independently championing the exact same thing, which we would never have known about apart from that network collaboration. And we've been able to learn from each other's experiences and improve our individual programs, and then even take that one step further. So we're currently conducting a self-organizing project within NPC-QIC that provides educational materials and mentorship and helps to guide other programs within NPC that would like to take on something like this. And so as a work group, we identified what our own key drivers, our specific aim, our key drivers, and what our change strategies would be. And we are currently piloting 2 programs through that process right now. We did, as part of the NPC annual survey, ask centers if they would want to do something like this if it was available at their center, and 84% of centers said absolutely this is something that they need. So I think what that shows is that each individual center has the ability through this framework to impact all of the other centers and truly all teach, all learn. This is just a picture of our Lurie team at Team Time. I think it's from last year, but you can see that we have a lot of parent partners that participate with us in these learning sessions. And I think as bad as COVID has been, one of the great things about it has been it's eliminated that transportation barrier where before our families couldn't always travel to these big meetings, but now that it's virtual, we've been able to have a tremendous representation of patients and families from all backgrounds who are able to provide us with their thoughts and their new set of eyes to help us identify how to best impact our patient population.